Today we're going to be talking about the pharmacological treatment of anxiety, panic, and PTSD. Our objectives are to review anxiety disorders, understand who might be at risk for them, understand the neurobiology of anxiety, and look at how treatments are decided upon. We're also going to look at different classes of medications, learn about alternative and complementary therapies, and then learn some clinical pearls for patient teaching. I included the CDC definition of anxiety disorders. It's here on your screen because I think it describes it really well. But basically, anxiety is an excessive and unrealistic worry about everyday tasks or events, and it affects pretty much everyone at some point in their life, but other people develop so much anxiety that it becomes a disorder and it needs treatment with therapy and sometimes medications. So, as I said, everyone experiences anxiety. It's a common human emotion, but it exists on a continuum. So you're supposed to feel anxiety in everyday life. Like if you're waiting for a train, you feel a little anxious if it's late and it looks like you'll be late to work. That's normal anxiety. However, if it turns into your heart is racing, you're feeling sort of panicked, then that might be pathological anxiety. So in the United States, lifetime prevalence of anxiety is 28.8%. It is more common in girls and women, except for OCD and social phobia actually. Those are more common in men. And anxiety usually manifests in adolescents with onset around 11 years old. Some of the risk factors include genetic loading, which means, if your family is prone to anxiety, then chances are you may have anxiety as well. Another risk factor is having limited range of coping skills, not learning coping skills when you're young, and also limited resources. A history of trauma and high levels of parental distress are also risk factors for anxiety. So, the neurobiology of anxiety. There are 3 chemicals in your body that are most implicated in anxiety disorders. They are serotonin, which we discussed when we were talking about depression, and it's involved in your well-being, and it's implicated in anxiety and depression. The theory is that your serotonin levels are dysregulated. Another chemical is called GABA, and it's an amino acid that works like a neurotransmitter, and it works in the central nervous system. It inhibits nerve transmission in the brain, so it has a calming effect. It brings down the nervous activity and the nervous energy. Cortisol is also implicated. That's a stress hormone. It's naturally supposed to be released when we're under stress, but for some people who experience pathologic anxiety, there's either too much or it's being released at different times, or in PTSD, there's not enough being released, interestingly enough. So anxiety presents physiologically, cognitively, emotionally, and behaviorally. It increases your heart rate, it makes you worry, it can give you a feeling of fear, sadness, and it can reduce your ability to perform or remember short-term memory. I wanted to include some more of the neurobiology of anxiety disorders. Whenever we talk about it, the HPA axis is brought up, so you should know about it. It includes the hypothalamus, the anterior pituitary, and the adrenal cortex. And these 3 different parts of your brain communicate in what's called a negative feedback loop. It's the natural way that we handle anxiety, and it is responsible for the fight or flight response that we should experience when we're under distress. For people who experience anxiety disorders, this is hyperactive. It's always on, a little too activated. So what are we trying to treat when we treat anxiety disorders? We're looking at a lot of the physiological representations of anxiety, and that includes trembling, shortness of breath, tachycardia, which is just an increased heart rate, dizziness, impaired attention and concentration, nervousness, edginess and tension, hyperarousal, which means always being on and just aware of your surroundings more so than other people, sleep-rest disturbance. In anxiety, it's usually difficulty falling asleep, and feelings of unreality, which means you're there but you don't feel there. You've derealized, you've kind of separated from your environment. All right, medications work in several different ways because there's multiple different medications that we use. Some of them block the reuptake of neurotransmitters, and those are antidepressants like we talked about last time. They also sensitize receptors located on the cell membrane of the postsynaptic terminus, and so that makes them more receptive to the neurotransmitter. Other medications potentiate the effects of GABA, so that's the neurochemical that has a calming effect. And other medications block the action of epinephrine and norepinephrine, which are sort of speedy chemicals in the body. The medication choices really depend on the diagnosis of the individual. So in this case, often diagnosis dictates treatment. Is it generalized anxiety disorder? If so, then we would treat with an SSRI or buspirone or pregabalin. Is it stress-related anxiety? If so, we could use something called a PRN, which is an as-needed medication. And some of the popular ones are Atarax, or a benzodiazepine, or even a beta blocker, which is a blood pressure medication but works quite well for anxiety. Are we seeing panic disorder? In that case, then we could use benzodiazepines, antidepressants, even MAOI inhibitors. Are we experiencing social phobia? For social phobia, we often use beta blockers as the first choice. That's the blood pressure medicine. It physiologically keeps your heart rate down so you don't have the physical representations of panic. We can also use SSRIs, venlafaxine, which is an SNRI, and we can also use MAOI inhibitors. For stress-related initial insomnia, which often happens with anxiety, we can use things like Ambien, very useful, or melatonin replacement. And for people with PTSD who are experiencing nightmares and trauma during the night, or remembering trauma during the night, we can use something called prazosin. So choosing a medication regimen, it always starts with psychotherapy, and then you have to decide, do you want to treat just short term? Are we looking at a couple of panic attacks during a stressful time in someone's life? Then maybe we'll just do psychotherapy and an anxiolytic like a benzodiazepine or buspar. Is it anxiety that's been around for longer than that and represents more often and is really impacting someone's life? Then we would use psychotherapy and antidepressants, and maybe on top of that we'd also use a benzodiazepine. First-line medications, very similar to treating depression. Anxiety and depression are kind of similar. They go together quite a bit. And so if somebody is treated for anxiety, often you'll find an underlying depressive disorder. And so we use the same medications to treat both. The first line is an SSRI, which selectively inhibits the reuptake of serotonin. And it's been known to reduce depression, but also control anxiety and obsessions and return a sense of well-being. All medications have side effects like we've discussed, and SSRIs are no different. They may cause weight gain, sexual dysfunction, like we talked about in the last video. We can also use SNRIs, that's the venlafaxine that I mentioned earlier, and it works for anxiety and has a few less side effects, no weight gain, no sexual side effects, or if they are present, they're a little less common. And the one thing about them is that they're really hard to get off of because they have a discontinuation effect. The other first-line medication is called buspar. A lot of people use that in conjunction with an SSRI, and it's a partial agonist for serotonin, or the precursor to serotonin, 5-HT. The only effect it has is to reduce anxiety. It's not really used to treat depression. And interestingly, the side effects include restlessness, nervousness, or unusual energy. So we're treating anxiety with something that may cause anxiety, but for some people it works. The examples that are most commonly used for anxiety disorders are Lexapro, Celexa, Zoloft, and Prozac. And like we said earlier, they work on depression and anxiety and PTSD, so they're really great meds. And Often we would decide which one to use based on which side effects the patient decides they can't handle, because they all have a different side effect profile, which we've discussed before. Further examples include Paxil and Luvox under SSRIs, and then also under SNRIs you can use Cymbalta as well, and that works well if the person has anxiety and chronic pain. Second and third line medications are, if the SSRI or the SNRI prove ineffective, then we would move on to an older class of medications, and those include the TCAs and the MOAIs. Basically, they work so well that you can associate being anxiety-free with taking a pill, and we try to avoid that. However, let's discuss them. So benzodiazepines, the first one marketed was in 1954. It was called Milltown. I just thought that was an interesting fact, so I'll put that in there. Benzodiazepines potentiate the effect of GABA, so they have a calming effect on the central nervous system. They are used for anxiety, they're used for sleep, they're also used as an anticonvulsant and a muscle relaxant. Types include Xanax, which is a very fast-acting medication. It's actually the most prescribed medication in the United States. It's a very popular drug. The only problem with it is that it creates a situation where people can develop tolerance quickly and also create cravings because it comes on fast and strong and then it leaves fast and strong as well, and so you may see rebound anxiety. Then we have Ativan, which lasts a little bit longer, maybe 8 to 12 hours, and so it acts quickly, but it has less of a drop-off effect at the end of it. Then we could use Klonopin, which has a much longer half-life, which means it's in the body longer and it does its effect longer, so it brings down the symptoms of anxiety for 10 to 18 hours. It's a useful medication if you're going to have someone on a benzodiazepine for a longer period of time. Usually these medications are used for 2 to 4 weeks, up to 4 months. They're sort of for the short term until your SSRI starts working and brings down the person's overall level of anxiety. They're not to be used every day for a year or more. That would be an SSRI. Okay. For sleep, we use non-benzodiazepine hypnotics. They work very similar to benzodiazepines, but there's just a different area in the brain where they work. And those include Ambien, Lunesta, and Sonata. We can also use Ramelteon, which is non-addictive and it works like melatonin. So it just increases your body's natural sleep chemical. And then also there are studies right now using GHB. It's popularly known as the date rate drug, and it's only available in one pharmacy. It's a very controlled subject chemical compound, and very few people have access to it. Side effects of benzodiazepines and hypnotics include sedation, CNS depression, and also mood disorders including depression. So anxiety medications, especially PRNs, bring your anxiety level down. They bring you low. And depression is a low mood, and so you can see the connection that if you are already depressed but you have anxiety and then we bring your mood low with a benzodiazepine, you have an increase in depression. Benzodiazepine should be avoided in the elderly because it increases the risk for falls, and it also can interact with quite a few different meds. And also recent research has shown that it's not a great med to use with someone who has PTSD. Actually, beta blockers are shown to work better for people with PTSD. For a long time, people with PTSD were treated pretty much with a benzodiazepine at first and then an SSRI, and the thinking around that is changing to treating with prazosin and an SSRI. Okay, so what would you teach a patient when they come in and they're expressing anxiety and you're going to refer them for a medication consult? There's several things that they should know about, and let's just go right down the list. So psychotherapy, stress management, relaxation training, regular exercise, sleep hygiene, biofeedback, and skills acquisition is all part of the treatment plan, and those are kind of the primary healing place. The medication will bring down the symptoms, but it won't heal the anxiety. That happens in therapy. Sleep hygiene is a really fascinating thing. It helps keep your circadian rhythm or your biological clock working regularly and functioning well, and it's an important part of anxiety. So I would always start there in therapy. There are multiple resources online where you actually can create a course with your client for sleep hygiene, and it has to do with going to bed the same time every night, waking up the same time every day, avoiding the bed except for sex and sleep, doing your reading in a chair rather than in your bed, and setting up sort of a ritual before going to bed. Also, people with anxiety disorder should avoid all caffeine. This is a really hard thing. Everyone loves coffee. Also, coffee has mild antidepressant effects, so everybody kind of craves it, especially when they're either in a low mood or when they're anxious to get stuff done. They may drink coffee, and then it increases your anxiety. An interesting fact about it is that if you consume more than 250 milligrams of caffeine in a day, you decrease your ability to reach slow wave sleep, which is very important for resetting your body, very important for bringing down anxiety. And so that would be 2 cups of coffee. Any more than 2 cups of coffee, and I'm talking actual cups, like 8 to 10 ounce cups of coffee. Any more than that, and you've kind of knocked out your ability to get a good night's sleep. Other things you'd want to teach are that daily medications often don't show efficacy until 4 to 6 weeks. That's really important when someone is anxious and needs right away relief. They need to have realistic expectations of what the medication will do, or they're at risk for kind of stopping early and seeing rebound anxiety and having things get worse. If the person is experiencing panic and anxiety, though, often we'll treat with a benzodiazepine and the medication that takes 4 to 6 weeks to work. So they'll feel relief right away as the other med starts to work. Minor tranquilizers, like I said, those are the PRNs. They'll work immediately, but the client should be aware that they're for short-term use only, so that they don't come to rely on that as the only source of treating anxiety. Neither medication should be stopped abruptly, so this is something we should encourage in therapy and in med management visits, that either medication can have really kind of negative and rebound effects if stopped abruptly or stopped without talking to the prescriber. Benzodiazepines particularly can send somebody into a seizure if they've been on them long enough, so it's sort of deadly to just stop them. And also, once you get further along in therapy, it's good to remind the client that exposure to an anxiety-causing situation may be part of the treatment, especially in, let's say, social anxiety. The person's going to have to get back out there and try again in the social setting while they're in treatment to see if it's working. Let's do a case study. All right, so a 24-year-old veteran recently enrolls at Hunter College. He was in combat while he was in the military, but he didn't have any negative effects. At least it didn't appear that way to him or his family. He felt euthymic, which means his mood was stable and good. He never needed to seek treatment before service, and after service he never needed to seek treatment either. Around midterms of his first semester, the student comes to the Counseling and Wellness Center and he reports feeling overwhelmed. His heart's been racing, he feels like the world is ending, there's this impending doom feeling, and he also reports he can't fall asleep. So, physiologically, what might be happening to this patient? Okay. In therapy, what skills might you want to teach the client? What would you want to ask him about his sleep patterns and habits? What PRN medication might be indicated? There are several that we could use, and maybe one we should avoid. What assumptions about this client should we avoid? And medically, what should be ruled out? And I'm going to answer these questions, and so we know we're on the same page. Physiologically, the patient may be experiencing an overreaction of the HPA axis. So he's having either too little cortisol or too much cortisol, and some of the neurochemicals are imbalanced. So not enough GABA, maybe not enough serotonin. Or he could just be experiencing his first semester of school, and there's just a little bit of normal, healthy anxiety, and it's reaching a level where maybe he's experiencing panic attacks. In therapy, I would definitely want to go over sleep hygiene with the client. I'd want to discuss reorienting to his surrounding. I'd want to discuss grounding and making sure that he feels present. And I want to rule out any signs of PTSD, which are re-experiencing night terrors, stuff like that. If his sleep pattern is off, if he's staying up late to do paperwork and do assignments, I would definitely want to start there and have him start going to bed at the same time every day, waking up at the same time every day, and actually, letting the assignments go if that's what's keeping him awake. So PRNs, we could use a benzodiazepine if it looked like he had no substance abuse issues and he was not experiencing PTSD and it was just the onset of some panic around academics. If he was actually developing PTSD from his wartime experience, however, then we'd want to go with something like prazosin and an SSRI. We should avoid the assumption, however, that he is experiencing PTSD, because PTSD is a complex disorder. It has a genetic component, it has an exposure component, and not everybody that's been exposed to a traumatic event actually develops it. So we wouldn't want to just go right to PTSD and miss some underlying patient teaching that we could do to help. And medically, for anybody that's seen trauma or experienced trauma, we should always rule out a head injury or a traumatic brain injury. And so I would always refer, even if the person is just coming for therapy, if they've seen combat or even a bad car accident or a fight on the street, they want to be seen by primary care to make sure that they're not experiencing a traumatic brain injury.